Hello everyone, this is Mark Gambale from the marketing team at Zoll Data in Colorado. Welcome today to today's webinar on the phrases of rejection and the words that lead to denied claims. Today we have a massive audience and I'm excited that all of you are here to hear the best practices from Steve Johnson. And just a little bit of housekeeping for today. Today's webinar will be recorded and a link to the recording will be emailed out a few days after the session. There is a question pane in the bottom of the webinar panel, so if you have questions along the way, please type them in there as you think of them. Steve will be answering them at the end of today's webinar. There is also a survey that Steve will mention, so pay attention to that when it pops up at the end because there are some incentives there for all of you. So I'm pleased to welcome Steve Johnson to today's webinar. He is the Director of Reimbursement Consulting with Page, Wolfberg & Worth, and the focus of his talk today is really to talk about best practices in billing and reimbursement related activities that really connect to all the activities that field crews are doing working hand in hand with your billing team. We have a broad audience today, so Steve will be doing his best to address questions as they come up and make this relevant for everyone. So without further ado, I'd like to welcome Steve.
Thank you very much, Mark. And good afternoon to most of you. Good morning to those on the West Coast. Before we jump into the phrases of rejection, we wanted to take just a minute to make you aware of a couple of additional benefits as a result of attendance on the webinar today. We'll start with this reminder on your screen now to get your summit registration in if you haven't already. I know I have, and I look forward to seeing all of you there. This will be actually my 7th year in a row of attending Summit, where members of the PWW team will be presenting multiple sessions again this year, and we've always been impressed with the tremendous number of sessions offered on so many important topics at Summit, and also with the great opportunities to network with so many of your peers. When you register, I see on the slide here that Zoll's offering a discount code, Phrases of Rejection, to receive $50 off your Summit registration. As a benefit of today's webinar, thanks a lot for that to the Zoll team. Also, we want to encourage each of you to complete the survey after the webinar today, as Mark mentioned, to be entered in a drawing for a $100 gift voucher, good for any of the products in the PWW Media online store. We really do appreciate your feedback, as it helps us to develop content that's relevant and most helpful to you and your organization. So remember, though, you do have to complete the survey to be eligible to win the gift vouchers, so don't bail out early. And now, again, I want to thank Zoll for the opportunity to talk with all of you about something that we see becoming a more significant issue all the time, something that we've labeled phrases of rejection, or words that we see often lead to misunderstandings resulting in denied claims. Because we're a law firm, we have to start out with our warnings and disclaimers and all of that basically say, if you're going to steal something, don't steal it from a law firm. And the information presented today is for educational and general information purposes. It's not legal advice, especially since I'm not an attorney. Therefore, no attorney-client relationship is formed by use of the materials, and the user at all times bears the responsibility for compliance with all applicable laws and regulations with regard to their documentation and submission. Any examples of documentation that we use today are exactly that, examples. They're just for illustration. They should not be used as templates or scripts. And I want to emphasize this, it can't be overemphasized. Your crew's documentation must be based on their independent objective assessment of the patient, must be honest, complete, and accurate at all times. So again, anything we talk about is not to be developed into templates or scripts, crews, or the patient as they find the patient. This webinar is approved for CEUs through the National Academy of Ambulance Compliance for all 3 of their certifications, the Certified Ambulance Coder, Certified Ambulance Compliance Officer, and Certified Ambulance Privacy Officer. And the CE certificates will be sent out after the webinar by Zoll. So with that, let's dive into the phrases of rejection. remember the old saying, sticks and stones may break my bones, but words will never harm me? Well, yes, we're talking about Medicare, in which case words do matter. In fact, they matter much. Poor choices of words can lead to documentation that does not clearly and completely describe the patient encounter, resulting in inappropriate decisions by billing staff, denials by payers either in prepayment reviews or post-payment audits, and all of that results in higher risk for the entire team. And one thing that I want to point out as we get started, keep this one overriding principle in mind, and this is particularly with regard to EPCRs. In the age of EPCRs, you have narrative areas on your electronic patient care report, and you have checkboxes. Well, we always like to point out that the checkboxes collect data and narratives tell the story. One thing that's true that you want to always keep in mind is that the people that audit claims, a very small percentage of the claims that they audit are ambulance claims. They audit medical claims of all types. And what they typically focus on is the narrative, because in the vast majority of claims that they see, narrative is what makes up the documentation. And so we recommend that as crew members are checking boxes on that EPCR, those should serve as reminders of things to further develop in the narrative. Checkboxes are great for things like NEMSIS and data collection, where you have to have consistent answers to specific questions, but they don't tell the full story. The information represented by those checkboxes needs to be more further developed narrative. So what are phrases of rejection? Well, it's things that lead to improper coding choices because of misunderstandings sometimes, claim denials in the case of a prepay review, or an unfavorable determination in a post-pay audit. In any event, we end up in a situation where we don't want to be. Now, because this is Medicare we're talking about, the billers in the crowd will recognize these denial and rejection codes. And these are some of the reasons that folks see claims denied. Information furnished does not substantiate the need for this level of service. Maybe a claim was billed at the ALS level, and they're saying there isn't sufficient documentation here to show that the patient needed ALS level care, and they suggest that perhaps the claim was overbilled in some cases. Or maybe claim service was chosen for complex review and was denied after we reviewed the medical record. These are not covered services because it's not deemed a medical necessity by the payer. And how would they deem it or not deem it a medical necessity? It's all based on the documentation written by the crew who actually treated the patient. And another one here, this decision was based on a LCD, a local coverage determination, or local medical review policy. Those are some of technically some of the denial reasons that we see on the claims, but they all result in we either don't get paid or we have money recouped. So phrases of rejection are phrases that make us and Medicare reviewers cringe when we see them. Too often as we review patient care reports, we just don't see a clear picture of the patient that supports the need for an ambulance during that transport. Phrases that really don't add anything to the narrative, and in fact sometimes make it very confusing and may actually accomplish the exactly the opposite of the intended result. And these phrases are those that are often specifically highlighted by Medicare reviewers and audits to support an unfavorable determination. In other words, when they give us a summary of why they denied the claims, they will often quote some of these phrases saying that they show there was no need for an ambulance. Now, before we look at the phrases, let's be very clear. You cannot purposefully omit truthful findings. You must always document the truth. Whatever the facts are, the facts are. And one of the things that I always tell crews as we do crew documentation training is we all understand that there are going to be some transports where an ambulance was not medically necessary. And so it is not the job of the crew to make every trip appear medically necessary. It is the job of the crew to paint an accurate picture so that people down the road can tell whether the trip was medically necessary or not. The other thing that's true is different payers have different standards for medical necessity, and so it's also not the job of the crew to say this was not medically necessary. Based on who the payer is, they may or may not know the standards for each payer, and they should be thankful that that isn't something they have to worry about. And so making the call as to whether it's medically necessary isn't the crew's job. The crew's job is to document the facts of the transport and let those who do have to know all those silly rules of all the various payers make an accurate determination as to whether the trip was medically necessary or not. And there's just one example here. Being able to ambulate does not necessarily mean that the ambulance transport's not medically necessary. So documenting that a patient ambulated to the stretcher, if that's what happened, that's what happened. And I will always tell crews, at the end of the day, the patient care report that is problematic is the one where we can't tell what happened here. As long as the picture is clearly painted and we know exactly what happened, that's what we need from the patient care report. So good choices are made down the road. So we're emphasizing the need to stop using sometimes habitual phrases and meaningless words. Also conclusions. We need facts documented, not conclusions. And so rather than documenting a conclusion, document the facts that led you to that conclusion, and that will give us good documentation from which we can support our decisions regarding our claims. So as we head into the 10 here that we're going to talk about today, first one, per protocol, and some variations on that, per RN, per MD perhaps. What the provider's probably trying to say here is that the intervention or service that they provided was necessary because the protocol says it is. Well, the reason that that fails is because relying simply on a protocol and not fully documenting the patient condition doesn't give us documentation that shows why it was necessary. Take, for example, a patient with chest pain. When the crew applies a cardiac monitor to that patient, for example, are they applying that monitor because someone many years ago wrote a protocol? Or are they applying the cardiac monitor because the patient has chest pain that they describe as substernal, crushing feeling, which they rate how many of 10, radiating where, and so on? It's those clinical facts that need to be documented to indicate why the monitor was applied, not the fact that there's a protocol. And so to ask perhaps is, what protocol is it? Why, what specifically about this patient's clinical condition made these treatments and interventions necessary? And are they being done without any clinical indication? Simply for the convenience of other providers. One that comes to my mind here, a few years ago, many years ago, I was at a site where they told me that all of our trips are ALS. And I thought, well, come on. Most communities that I've been in, there's at least one person who will dial 911 for a silly reason. And really, all of them are ALS? And I was told, well, everybody gets an IV, so they're all ALS. And I thought, well, that's a pretty gross overstatement. I mean, not everybody gets an IV. And I was told, per protocol, if you come in the back of my truck, you will be stuck. There are no exceptions. And protocols like that are exactly the reason that this per protocol is a problem in documentation, because auditors who will always suspect the worst of you suspect that that's the type of protocol we're talking about. There was no medical necessity. There's simply a protocol that says do that thing, so you did that thing. And so the documentation needs to be such that it shows that that's not the case. Give us the clinical reason for IVs and EKG monitoring. Interventions need to be medically necessary, obviously, in order to show justification for that intervention and transport. One other example that we see sometimes with regard to dialysis patients especially is we're told that they require ambulance transport because the individuals at the receiving facility have a protocol that says they will not assist in transfer of the patient. Therefore, ambulance is medically necessary. Well, sorry, according to Medicare, no, it's not. The fact that that facility has a protocol that their employees won't offer assistance in transferring the patient doesn't make ambulance transport medically necessary. And so that's just one more example where per protocol indicates there wasn't really a medical reason for this intervention or for ambulance transport. It was just a protocol. So some things to think about from a compliance standpoint with regard to that one. What protocol was followed and why? What specific clinical findings made that intervention necessary? What interventions are expected to be provided with that protocol? Were they provided? How did the patient respond to that? Those are the types of things that need to be documented for each intervention, not just per protocol. Okay, number 2, unable to answer, and some variations on that one. Unsteady gait, ataxia, found in bed, patient bed confined, found in seated position, moved by two-person lift. All of those kinds of statements are, when we see them, we think, well, that's interesting. Why? What the provider's trying to tell us in many cases, not always, but in many cases, is that this patient's bed confined. Well, but that's not what they said. They said the patient was non-ambulatory. Keep in mind that having difficulty ambulating or even being completely unable to ambulate does not by itself necessitate ambulance transport. Some things to ask yourself on this one. What objective findings led to a conclusion that the patient was unable to ambulate? Was the patient actually bed confined? I'm thinking of the one that we frequently see, patient found in bed. Well, I tell you what, if you come to my house at the right time of night with any luck at all, you'll find me in bed as well. But that doesn't mean anything other than I was sleeping. And it certainly doesn't mean that I'm bed confined. So is the patient actually bed confined? If so, use the right terminology. And understand the 3-part test of bed confinement and realize that unable to ambulate is just one of the 3 parts of the test. So stating non-ambulatory is not communicating bed confined, and sometimes we find that people think it is when it really won't when it comes time for a claim on it. If the patient is bed confined, how do you know? How do you know that they're bed confined, and how long have they been bed confined? Those are some questions we'd want to know. And again, remember, inability to ambulate is just one component of that 3-part test. Also, doctor-ordered bed rest is not the same as being unable to ambulate. We're talking here about a physical inability, not a hardship or a doctor's order. So some questions to ask. Is the patient's inability to ambulate documented perhaps in other records from other clinicians? Or can the patient tell you how long has it been since they've been out of bed? Is the patient able to ambulate with assistive devices and so on? Unsteady gait or ataxia is very common, but patients with unsteady gait can still be ambulatory. As we see here, abnormal gait doesn't prove somebody needs an ambulance. It just means they walk different than some of the rest of us. So found in seated position or found in bed, we already kind of talked about that one. That doesn't mean that they can't ambulate or that they're bed confined. We can't assume that the patient's unable to ambulate or unable to get out of bed simply because they were found in bed. Moved via 2-man lift or transferred by a sheet draw doesn't prove bed confinement either. Was there a clinical reason that this type of transfer was used? And that's one of the things that we always see when we always think when we see moved by sheet draw. Why was that? Was that because it was convenient for the crew? I know from my years in the field, many times the reason we used the sheet draw to move the patient from the bed they were in onto our stretcher was because that was the easiest way for us to get them there. We could roll the stretcher up there, make it match the height, grab the sheet, get one person on each side of them, and slide them, and we're done. Now, does the fact that we did that mean that the patient couldn't have been moved some other way? Or was it just for our convenience, was the patient able to assist with that transfer? And if so, to what degree? Areas involved here, sometimes seeing non-ambulatory or two-person sheet draw causes folks to assume more severe conditions exist than really do. And keep in mind that inability to ambulate does not equal bed. As far as compliance considerations here, just better documentation of those words that we often see. Rather than gait deficit or gait defect, describe it. And how was the patient transferred to the stretcher? Again, to what degree were they able to assist with that transfer? And if they are bed confined, how long have they been bed confined, and so on. Okay, number 3, weakness. Some variations on that one: unable to bear weight, maybe general weakness, fatigue, or drowse. Usually what folks are trying to say here is that the patient can't tolerate other forms of transport due to that condition, whatever it is. But the reason that it fails is it's a very non-specific conclusion. Weakness is a conclusion. What did you see in your patient assessment that made you decide that the patient was weak? Unfortunately, it's often a fallback in documentation. And as the sign says here, weakness is not a reason, just an excuse. But the point that we're trying to make is that weakness can derive from many things. There can be past medical history that can leave patients weak. Generalized weakness may be deconditioning due to inactivity. All of these things listed here. One of the things that is sometimes, I think, very helpful is quantify the weakness. Much like we talk about a pain scale, what about this muscle strength scale when we're talking about weakness? It gives a scale of everything from full strength to no visible muscle contraction. And it's just a nice, quick way to quantify that weakness to show that there was a patient assessment done here that arrived at that conclusion of weakness, and to what degree. How is that weakness manifesting itself? And again, when did it start? What does it prevent the patient? What can the patient do? What can't the patient do that makes you state that the patient is weak? Do the patient's medical records perhaps reflect some underlying cause of weakness? And again, range of motion, effect on the body. Weakness alone does not equal medical necessity for ambulance. One of the things that we often suggest is a patient mobility report that we've developed a sample. There's a picture of it here, and it's included in the handouts that Mark has said that you'll be receiving after the webinar. This is the last page of those handouts. And this is often helpful to folks, especially with regard to those scheduled repetitive non-emergency patients. And while it can be good to have the crews go through this patient mobility report, very often this is used as an independent assessment of those patients at times in addition to time of transport, to document that patient's mobility status, ability to perform activities of daily living, and so on. So again, with weakness, some compliance considerations there. Describe the weakness. What caused it? How long has it been going on? And consider the use of that muscle strength scale, again, to help quantify weakness. Okay, number 4, not wheelchair capable. Not sure what it means. I suppose perhaps the guy in the back is a little more wheelchair capable than the gal in front. I'm not sure. But anyway, what the provider is likely trying to say is that the patient cannot safely be transported by a wheelchair van or by means other than an ambulance. Unfortunately, on many of the patient care reports where we see this stated, we also find that the patient was found seated in a wheelchair. In states where it's allowed, maybe a non-medical stretcher van would be an option here. But again, not wheelchair capable does not necessarily mean that the patient needs ambulance transport. Some other questions to ask are other bed confined criteria also met? You remember the bed confined criteria: unable to get up from bed without assistance, unable to ambulate, unable to sit in a chair or wheelchair. So here again, if we're documenting they're unable to sit in a wheelchair, what about the other two bed confined criteria? Are those also met? And by the way, while I'm on that, it is always best to document the facts. Again, patient is bed confined. Better to document that the patient is all three of those points: unable to get up from bed without assistance, unable to ambulate, unable to sit in a chair or wheelchair. The reason for that is the ambulance definition of bed confined is different than, for example, the skilled nursing facility definition of bed confined. And so if the documentation simply states bed confined, it leaves open the possibility that we don't know which standard was used, that some auditor could claim. And so better to document the 3 points and make it clear exactly what we mean, that all 3 of those points are true of this patient. For example, if a patient can sit in a wheelchair for a few moments at a time while they change the bed linens in the SNF, but due to severe sacral ulcer and so on, they can't be transported sitting on that, document that. Areas, inability to sit, again, is not by itself something that makes ambulance medically necessary. And too often we see insufficient documentation as to the physical condition and the reason for the patient's inability to be transported in a wheelchair. Keep in mind that medical necessity for ambulance transport exists only when all other means of transport are contraindicated, not only when they're unable to be transported by wheelchair. There's an important difference there, especially in those states where stretcher vention. So some things to keep in mind here: ask how the patient normally moves around. Determine how they're transported to other appointments. You know, one of the best ways, I think, to find out whether a patient's bed confined, we sometimes run into that question: well, how should I know if they're bed confined? Well, maybe don't ask the question, are they bed confined? Something like, is the patient able to use the restroom unassisted? If the answer to that is yes, they're not bed confined. And so many times there are other questions that you can ask that will get to the point that you're really trying to get at. What medical conditions makes that patient not moved in a wheelchair? Oh, number 5, this one, transported without incident. I tell you what, every time we see that, we more than cringe. Some variations on that: vital signs within normal limits or maybe not recorded at all, transported in position of comfort, whatever made them feel good today, not sure what that position was, or no services rendered. So when we see transported without incident, we wonder, well, what does that mean? Does that mean we didn't do this on the way to the hospital? Well, really, shouldn't that go without saying, that we won't do that on the way to the hospital? What the provider's probably trying to say is that the patient suffered no harm during the transport or no significant change in patient condition. But I will tell you that the way that statement, transported without incident, is interpreted by many auditors is there was no medical reason for putting this patient in an ambulance. There was nothing wrong with the patient. We didn't do anything. No reason they needed to be in an ambulance. And it's very unfortunate how they interpret it. But better to say patient transported, document your assessment, patient condition as documented. But this transported without incident, those words are very problematic. And it's one of those things that is often a habitual thing that folks will just write on every patient care report out of habit. And I would strongly recommend that you think about what did you mean when you said that and write what you meant rather than those words. What services or interventions were performed and how did the patient respond to them? How could the patient have been harmed if other means of transport were used? And if no, because here's the, at the end of the day, if no services were necessary or provided, why couldn't that patient have gone by some means other than an ambulance? And so again, when those auditors see transported without incident, what they take that to mean is other means of transportation was fine. Medicare auditors, like I said, interpreted as nothing was done for the patient. So maybe consider banning that phrase from all PCRs. And I tell you what, there are very, very few things. In fact, this may be the only thing that I would ever say, just don't write that on a patient care report. It is always misinterpreted by auditors, and it is just problematic. What we need is clinical and operational documentation that tells us what we did for the patient and how the patient responded to our treatment and explains why this patient was in our ambulance. Number 6, transported for level of care. Sometimes I think that might make a great bumper sticker for a hearse, but anyway, what the provider's probably trying to say is that the patient required services that were not available at the facility of origin. Here again, if that's what we mean, then that's what we should say, including the specific service the patient needed, why they needed it, the fact that it wasn't available at the facility of origin, and why not. What about the patient's condition at the time of service, and not just past medical history, but their condition at the time of service explains why transport by ambulance is necessary. Okay, because there's two questions going on here. What service did the patient need? We have to first establish that there was something the patient needed at the second hospital, if we're doing a hospital-to-hospital transport here. What did they need at that second hospital that was not available at the first hospital? And once we've established the need for that, the medical necessity for that service itself, okay, now assuming they needed it, why do they have to go by ambulance to get it? Why couldn't they be transported there some other way? And so two things have to be established. What did they need? Prove they needed it. Now, why did they have to go by ambulance to get it? And that's what has to be on the patient care report in those cases. Sometimes we'll see individuals telling us that higher level of care justifies ALS, or higher level of care justifies emergency level billing. Not true. Those are clearly identified by Medicare, and those definitions must be met. The criteria for billing at those levels must be met. Going interfacility hospital to hospital does not change the definition. So could the patient have been safely transported by other? So some compliance considerations on that one. Why was the patient being moved? What specific service did the patient need? And how do we know that that service was not available at the facility of origin? That becomes important when especially services that a given facility can many times provide, they can't provide today because the specialist they need isn't here, or for whatever reason. If that's the case, that has to be clearly documented to show why didn't we just treat them where they already were? They were already in a hospital. Why did we move them to a different one? Okay, and then pain. Some variations on that. General body pain, no pain scale noted. Pain not described or quantified. Maybe decubitus ulcers, but no documentation of stage, location, anything like that. What probably the provider is trying to say is that transport by other means is contraindicated because of the patient's pain level. Unfortunately, too often, like I said, it's not qualified or quantified. And why would it be exacerbated if the patient was moved by some means other than an ambulance? One thing that can be helpful to the providers is perhaps this Wong-Baker scale. I know that there are some providers that use this, for example, when administering narcotics. We'll see documented both a pain scale 1 to 10 and also a Wong-Baker scale. And some folks have protocols that both have to be there because you get those patients that they want the narcotics, and so they'll tell you it's a 10. But a second form of verifying that can be perhaps the Wong-Baker scale. What's the scale on that? And one thing that I find interesting about this is that apparently proximity to the event changes your impression of what's going on. Notice how this guy apparently is a little bit concerned about what's going on, and the people further back in line don't see it as such a big deal at all. We need more than just the pain scale. We need a description of location, character, type, what either makes it better or worse, what did it start, when did it start, and the full OPQRST of pain. More than just letters of the alphabet, as it says. One to tell you about this one, we recently had a case, an audit, where the auditors, anytime the word pain appeared and it was not accompanied by a pain scale, the statement that they made in denying the claim was, conclusion of pain not supported in the documentation, therefore insufficient documentation to support medical necessity for ambulance, claim denied. And so one thing I will tell you for the crew members on the call today, anytime you're documenting the word pain, always, always, always include a pain scale with that. And not just the pain scale again, but the full OPQRST of pain. Fully develop that conclusion of pain, or it can really cost you down the road. Pain alone does not prove medical necessity for ambulance transport, as it says here, but every occurrence of pain must be completely described and quantified. And that documentation should be both quantitative as well as qualitative. In other words, for example, it describes the pain as sharp and stabbing. That's the quality. Patient rates the pain 8 on a 1 to 10 scale. There's the quantity. So we need both of those, the full OPQRST of pain anytime pain is documented. Specific location, where, when did it start, what makes it better or worse, all of that anytime we're talking about pain. Okay, number 8, abnormal labs, and some other variations on that theme. I guess abnormal lab. But what probably the provider is trying to tell us is that the patient has an underlying medical condition that requires evaluation at an acute care hospital. Well, what is that? Why is that the case? Why do we think that? And typically we see not enough detail as to why those conditions would make transport by means other than an ambulance inappropriate. And so some questions to ask yourself when we're thinking about abnormal labs. How is that manifesting itself? Lots of us have abnormal labs or abnormal vitals. I'm sure I do most all day, any day, have vitals outside the normal range, but it doesn't mean that I need to be in an ambulance. If there's no patient complaint, why do we need to be transporting the patient at all, and especially by ambulance? When we're giving oxygen, why is the O2 needed? Could the patient self-administer? Some risks there, generic and vague statements about past medical history or general condition, rather than focusing on the patient's condition at the time of transport, can lead to assumption coding. For example, billers that see oxygen on the patient care report, do they jump to the conclusion that that oxygen was medically necessary even when the documentation does not show whether it was or wasn't? We can see that it was given, but there's no indication as to why it was given and whether it was medically necessary. Not every abnormality translates into a need for transport. So no specified complaint is clearly a red flag. We sometimes see that as the chief complaint, no specified complaint. I'll tell you where that's going to go in an audit. I bet you can guess. So some compliance considerations, crew patient assessment skills maybe need to be refined and sharpened. I think that many times we just need to help crews understand how their documentation is interpreted by those who audit claims. You know, one of the sad facts that not everyone realizes that it would be good for everybody to understand is that those people who adjudicate your claims and decide whether they're payable or not many times have absolutely no medical background at all. And so it would be very helpful if crews understood you need to write your narrative especially, but you need to write your patient care report in a way that somebody with little or no medical training would understand what's going on, what you were doing for the patient, and why. Documentation of the current patient condition, that why is ambulance transport medically necessary? Number 9, emergency transport. We'll see things like lights and sirens from the scene, code 3 required to the hospital. Well, probably what I'm trying to say here is the transport from the scene to the hospital was done emergently due to some immediate need of the patient. The problem is, from a billing standpoint, and this actually started back in 2002. This started with the fee schedule. The definition of emergency from a claim perspective changed. And there are two often very opposing definitions of the word emergency out there. To many crews, emergency and non-emergency refer to whether we have red lights and sirens going or not. That is not what that word or those words mean to Medicare at all. Emergency response level billing under Medicare rules is based on the dispatched condition, which we all know. Often we get on scene and find a different patient condition than what we were told by dispatch. But emergency response is based on the dispatched condition and the response to the scene, not the mode of transport from the scene. And so patient actual condition on scene is not determinative of is this claim an emergency or a non-emergency claim. And many times that point where things fall apart, because I will agree, it doesn't make a lot of sense if you don't understand why they did what they did. So the things to ask with regard to emergency level claims now for the billers: was there a qualifying emergency level dispatch? Do your system's dispatch protocols clearly specify when an emergency response is necessary? And was there that documented emergency response? Keep in mind, use of lights and sirens is not the definition of emergency. Neither is transported hot from the scene. And so our objective requirements for emergency response clearly documented. Do we have good, clear documentation of the nature of the call at the time of dispatch? That should be documented on every patient care report. If your system uses the EMD codes, those EMD determinants should be clearly documented on every patient care report. And both the crews and the billing office should have copies of those protocols and clearly understand how they apply. Time call received and time of response are important in helping to establish did we or did we not provide that immediate response. And if there are any delays, clearly document the reasons for those. And finally, number 10, referred to stretcher with assistance. Some variations on that: moved to stretcher, pulled to stretcher, slid to stretcher. And like I mentioned before, was this done out of convenience for the provider, or was this done because based on patient condition it was the only way to get the patient there? And many times one of the other things that we see is it's not clear who assisted who. In other words, did the crew assist the patient to the stretcher, or did the crew slide the patient to the stretcher with minimal assistance by the patient? Type of assistance often is not fully described, and again, who assisted who? Did the patient, were they pretty much able to do it themselves, or were they practically unable to even assist in this transfer? So how independent was the patient in the process, and what type of assistance could they give? Because that assistance is a very vague term. We need to know the precise manner in which the patient is transferred both to and from the stretcher, what degree of assistance they were able to provide, if any, and again, whether they were largely in or it was pretty much the crew that had to move them because this patient was unable to assist with the transfer. And in that case, why? And then here I wanted to throw in one bonus global troublemaker in addition to those 10 phrases, just kind of an overall, the big troublemaker we see is inconsistent documentation. In other words, contradictions within the PCR itself. When, as we say in the second bullet here, when it can be proven that one part of your patient care report simply can't be true, because in reading the patient care report, I see you say one thing in one area and something else in another area. Take, for example, documentation in a narrative versus documentation on an anatomical view. And on the anatomical view, you tell me that the patient has a right above knee amputation, and yet in the narrative you tell me that the patient moves all 4 extremities well and has good pedal pulses in both legs or both feet, whatever. When you see that kind of an inconsistency, here's what happens in an audit. Once we can prove that any one tiny little statement in that patient care report cannot possibly be true, that now throws the whole thing in question, because we know something's not true, but we don't know what's not true. So maybe the whole thing's not true. And that is the road that they tend to go down. So make sure before you sign your patient care report and turn it in to the crew members on the call, make sure you read it, and that you read it with a critical eye looking for those inconsistencies, because those are exactly the things that they'll use against you. So some application to this, these 10 phrases consistently. We see these on patient care reports, and very often it is those phrases that are causing the trouble in the claim reviews and the audits that we're assisting with. So how do we move forward? We need to emphasize the importance of clear, complete, consistent crew documentation. For the crews on the call, make sure your patient care report does not contradict itself. For the billers on the call, when you see a patient care report that contradicts itself, don't assume that you know which one is accurate. Send it back to the crew, get the inconsistency cleared up so that we have documentation that will support the claim that we're sending in. Returning PCRs to the crews for clarification is not only okay, it absolutely should be done when we don't have documentation that will stand on its own. And stick to objective facts, no conclusions. So for the billers, no assumption coding. Don't fall for those buzz phrases. If there's something on a patient care report that you're not really sure exactly what that means, well then you're not really ready to bill the claim yet. Make sure that you do understand exactly what it means before we send the claim out the door, because to do otherwise puts the entire organization at great risk. For many of the interventions documented on a patient care report, why? Why were those necessary? So like we said in the beginning, words really do matter. Choose them carefully. And as we say here, what you put up with, you end up with. So for the entire organization, focus on raising the bar and improving your organization's compliance each and every day is the goal that we should be striving for. And so now we'd encourage you to send in your questions if you haven't already, and as we compile those, we want to take just a minute to make you aware of a couple of other ops. First of all, you can sign up for our news releases at our website listed here. And I want to make you aware, if you're not already, of the PWW ABC3 Spring Conferences, ABC 360 Spring Conference Series, beginning actually this coming weekend in Las Vegas. These are the dates for those conferences. and the website where you can sign up. We always enjoy seeing many of you throughout the year at our conferences in Hershey in the fall, and then 3 locations in the spring that kind of move around sometimes. And also as a reminder, get your registrations in for Summit. We look forward to seeing you there. Myself and Amanda Ward, I believe, will be presenting at Summit this year. Some various topics there. Don't forget your discount code based on your attendance at today's webinar, and we thank Zoll again for that. And finally, don't forget to complete the survey following our Q&A here in order to get entered in that drawing for the $100 gift voucher. It's good for a year from today for any of the products in our online store. And I'd like to thank all the good folks at Zoll for the work that they put in to bringing you this webinar. We really do appreciate the opportunity to work with them on this webinar series. And we want to thank all of you for joining us as well. Finally, before we head to Q&A, to learn more about Zoll and any of their fine products, you can contact Sandy Smith at the phone number or email address seen here. And with that, Mark, is there anything you'd like to add? Otherwise, should we do some questions?
Yes, Steve, thank you so much for going through all that great content. I can tell that it's really struck a chord with our large audience today. There's just a ton of questions that have come in. So let me see if I can pick some of the key ones that have been repeating here. First question here is from Janice, and that is, our crews are dispatched by our 911 center. They do not tell the crew how to respond except when the caller requests no lights or sirens. So how are we to bill accordingly to dispatch?
Yeah, that's a great question, and one that we do run into quite frequently. One of the things that there's a couple of variations on that, and let me just address both of them. In some cases, what you get from the PSAP is just simply we need an ambulance with no indication at all of what's wrong with the patient. In some cases, you do get from the PSAP an indication of what's wrong with the patient. So if you get absolutely nothing, what the Medicare rules say about that is that basically you lose access to the ALS assessment rule. If you don't have good, clear dispatch protocols that establish patient condition at the time of dispatch so that you can make those right vehicle allocation, crew allocation, and so on to that transport, the ALS assessment rule is off the table for you. And that's really at the end of the day what it comes down to. If your PSAP does give you patient condition, maybe you get an EMD determinant, but not everything that you would like. Maybe you don't even get that much, but you do get some patient condition information. In those cases, I would work with your medical director. The medical director can still establish dispatch protocols based on the types of information that you do get. And I think I didn't complete the first thought. If you get nothing other than we need an ambulance, so you don't have the ability to develop those protocols, what Medicare says is that where no protocol was used, patient condition on scene determines level of service billing. And so that's why I'm saying at that point you lose the ALS assessment rule, because basically what the ALS assessment rule does is it gives you credit for a medically necessary ALS emergent response to a patient that ends up not needing ALS level care. Well, if you didn't have that medically necessary response based on dispatch information, you haven't met the criteria for the ALS assessment rule.
Great, thank you, Steve. Here's another question. How do we make hospitals understand medical necessity and not because it's most convenient for the family when it comes to EMS transports? Yeah, the issue of the hospital just needs their bed freed up, and so they will call the ambulance to get the patient out of there because they need their bed. That is a tough one because there's a couple of answers to that, and I don't even like one of them. And the one that I don't like is
you could have the crew have that discussion with the family at the time of service that, okay, we don't believe this is going to be covered. We're happy to take you, but you're probably going to be responsible for the bill. In some cases, some organizations do choose to do that. I know that crews will hate that, but at the end of the day, it gives an opportunity for the organization to have the patient sign an ABN saying, now an ABN is not required in this situation. It's a situation where you are allowed to use one but not required to. And many organizations have found that if they do that, and the patient has agreed up front that they'll be responsible for the bill in cases where it's not medically necessary, that the patient is actually more likely to pay that bill once they receive it. Probably the first place that I would start, though, and an option that I like a little better, is getting with the hospital's compliance folks. Talking to the nurse on the floor isn't going to get you anywhere because she just wants her bed freed up and is going to call for the ambulance in order to get the bed freed up. But if you can get to the compliance folks and help them to understand the potential compliance risk to the hospital for getting caught up in what is perceived by auditors to be a scheme between the hospital and the ambulance of getting these transports paid by the Medicare Trust Fund when they really shouldn't be, sometimes those compliance folks can get to the ops folks at the hospital and say, hey, knock it off. You're putting risk on our organization by doing this. And so a combination of the two is often where the solution ends up being, and I will readily confess that it's not an easy fix.
And Steve, here's one from Wendell. Does the ambulance transport necessity criteria differ for rescue squads, fire departments versus transport companies, and how does this webinar today apply to 911 agencies?
Great question, and the answer is no, it doesn't change. The medical necessity definitions are what they are, and here's Medicare's definition of medical necessity. All other means of transport are contraindicated. Okay, that is the definition of medical necessity as put out by Medicare, and as we can all see, that's not really black and white. But that is the definition, whether we're talking about emergency trips or non-emergency discharges and so on. Medical necessity is medical necessity. And the fact that somebody dialed 911 does not make a trip medically necessary. Like I said, most any city I've ever operated in, somebody there will dial 911 for a silly reason. And so while it may mean that you have an obligation to respond, that does not obligate the Medicare Trust Fund to pay for it. And so the short answer to the question is no, there is only one definition of medical necessity, whether we're talking emergent or non-emergent transports.
Here's a question from Brad. Steve, how do you feel about those system-generated narratives?
I hate it. Oh, was that my outside voice? Let me give you a more complete answer. System-generated narrative is an interesting tool, and it can be a good tool if used properly. The reason that I hate it is I see too many people use it inappropriately. In other words, what they'll do is they'll fill out a bunch of check boxes. The system generates a narrative. The crew never reads it, turns in the patient care report, and then somebody ends up on a witness stand defending a narrative that doesn't even make sense when you read it. Many of those systems do a very poor job of consistently documenting a narrative that makes sense, frankly. I mean, I've seen things like one example that comes to mind that I saw a couple of years ago. There was a system-generated narrative that said cardiac monitor was not applied. Monitor shows normal sinus rhythm. Okay, well, you better check your monitor. I think it's broke. It's showing normal sinus rhythm while connected to nothing. But that's what the narrative said. And system-generated narrative can be a great tool if everybody understands that that's all it is a tool to kind of put some stuff there that would be good to include in your narrative, but now somebody needs to go through that with a fine-tooth comb and make it say what it really needs to say, because most of the time there's something in there that's completely ridiculous.
So here's a question from Chris. After hearing your talk today, will I need to write a novel then to justify a transport now?
That's a good question. The quantity of the words is not the thing. The clarity of the words is the issue. And so write a novel, I wouldn't say that, but write enough that we paint a clear picture, yes. And so do we need good, clear documentation? Yes. Is the best documentation that uses the most words? No. Good, succinct documentation that clearly paints the picture is what we're after, not word quantity. But something like patient transported from hospital to SNF, patient rested comfortably en route, being the sum total of the narrative is clearly not good enough. And like I say, let those check boxes that you're checking, when those are things like pain or weakness or something that needs to be more further developed, let those be red flags in your own mind as you check those check boxes of, and I need to more carefully develop this in my narrative. And so simply repeating the information from the check boxes is not what I'm suggesting here. I'm saying that those check boxes are good triggers of things that you need to color in and paint the picture of in the narrative, not just simply repeating the words of the check boxes.
So there's a ton of other questions that have come in here. I'm trying to pick the ones that kind of cover most of the questions. Here's one from Steve. If a problem is actually found within a run report, is it better for the crew to change that actual report or maybe do an addendum to clarify?
That depends on the stage of the report. If the crew has not yet closed the report, just make the report right before you close it and sign off on it. If it's a matter of this report's been completed and sent on either to QA or to billing, and somebody comes back and points out an inconsistency or incomplete thought in the patient care report, for example, where you need to change that, it is absolutely best to do that as an addendum. Don't make addendums added later try to appear as contemporaneous documentation. That'll get you in trouble. The documentation is what the documentation is, and once it's closed, can it be corrected? Absolutely, and it should be corrected. But the right way to correct it is to show who made the correction, when, and why.
So here's a question from Timothy, and the question is, do we need to leave all opinion out of our EPCR notes?
Unsupported opinion, yes. If there's going to be any opinion at all, it needs to be backed up by facts. And so if I suspect something, if I think something, if I want to document an opinion, that opinion is based on what hard evidence that I found during my patient assessment. As a general rule, opinions and conclusions don't belong in a patient care report. The facts belong in a patient care report. But would I go so far as to say it is never, ever, ever appropriate to put any opinion in a patient care report? I think that's a bit extreme, but as a general rule, yes, I would say the patient care report should be the facts, not the opinions and conclusions.
All right, Steve, we have time for just a few more questions, and we're just a little bit beyond the promised hour, so I'll ask those right now, and then we'll close out today's webinar. Is there a minimum character count for a narrative, or is it just so hard to define that?
Because I'm not sure of the role of the individual asking, let me give you two answers. From the crew standpoint, there's no character count that matters. We need a narrative from the crew that paints the full picture of the patient encounter and the patient's response to the treatment. If we're talking to a biller, and if we're talking specifically about the billing narrative that I believe is on the second tab in Zoll, if I'm remembering right, that billing narrative does have a character limit when you transmit your claim. It's limited to 80 characters per charge. Since typical ambulance claim is a base rate and a mileage, there's two charges, therefore you'd have a limit, a maximum limit of 160 characters for the billing narrative. But again, for crews, there's no character limit.
And here's a question from Maria. Is it okay to bill ALS when ALS assessment is performed without any ALS intervention?
As long as you meet all the criteria for the ALS assessment rule, yes. And those criteria include, first of all, you have to have good dispatch protocols. You have to have good documentation of the dispatch and of the response and of the ALS assessment by an ALS provider. So the pieces that have to be there, again, the protocol. It's got to be an emergency dispatch. ALS assessment never applies in a non-emergency transport, emergencies only. So it would have to be an emergency response. It would have to be a medically necessary ALS response based on the protocols. And then we have to have an ALS provider document an ALS assessment. And if that assessment results in a finding that no ALS interventions are necessary, then yes, in those cases, it's appropriate to bill at the ALS-1 emergency level. But each and every trip has to be verified on its own that it meets all criteria for the ALS assessment rule. And I would just encourage you to look in the Medicare Benefit Policy Manual, Chapter 10 lays out the definitions, and the definition of the ALS assessment rule is in there. So make sure you're complying with the definition of ALS assessment. And when you're doing that, yes, billing at the ALS level is appropriate.
All right, so here's the last question for the day. There's just so many that have come in. There's a lot of repeats, so hopefully we've covered everything from everyone. But are there any ways that you know of to get paid for patient refusals?
Well, it depends on who the payer is. Most of the training that we do tends to focus on Medicare. From Medicare, no. There are some of the commercial payers who will pay for a treat no transport. So for example, I'm thinking of the diabetic emergency where you respond to the patient's home, you give them their sugar, and they come around and say, I don't want to be transported to the hospital. So we're talking about treatment without transport resulting in a refusal because of that. There are some of the commercial payers that will pay for that. Typically the appropriate HCPC to use for that is the treat no transport HCPC, not one of the transportation base rates. But some of the commercials will cover that, yes. Medicare will not.
Great, thank you, Steve. So this is Mark Gambale again from Zoll speaking. Thank you so much for sharing all of your time and expertise today. As I mentioned, today's webinar was recorded, and a link to the recording will be sent out within a few days along with Steve's handouts. So thanks again, Steve, and everyone in the audience who asked such great questions today. Thank you again.
Thanks, everybody. We'll see you at Summit.